title is Two Infections, Double the Trouble. Okay, so this is the case. We have a 73-year-old Chinese man presented back in 2011. He was diagnosed as having a cataract and an appearance on the endothelium that was made a diagnosis as being possible Fuchs, basically with cataract. He had an uncomplicated ultra-thin phaco DSEC back in 2014. He's known to have ischemic heart disease on basis on warfarin. His visual acuity picked up to 612 basically after surgery. Cell count was pretty good, 1800, and this is basically about 3 months after surgery. He then came back 8 months after his surgery, and his basically cornea looked like this. He has this inferior area of edema with a few KPs, very minimal anterior chamber activity. So the first question is, what is the cause of this edema? So inferior edema, bit of KPs, very little AC activity. Is it a rejection? Could it be a viral, either CMV or herpes simplex, or is this basically graft failure? Okay, so we have rejection, CMV 41%, 29% HSV, and 12% graft failure. Okay, so I mean, so most of you probably picked up on the fact he's Chinese, so Chinese have a higher rate of CMV. It's a bit early for graft rejection following DSEC, and so what we did was we did an AC tap for him, and he has a 31,000 copy number following his basically AC tap. So of course the diagnosis is basically CMV. It's very typical. It's inferior edema, these brown lesions, pigmented lesions on the anterior chamber with very minimal AC reactivation. So what would you do next? So increase his steroids, start antiviral therapy, stop his steroids and start antiviral therapy. Okay, so 50, that's perfect. 56% say increase steroids, 44% say stop steroids. Okay. With CMV endotheliitis, you must stop the topical steroids. It's the commonest mistake that people basically make. If you continue steroids, you're going to decompensate the whole cornea. So after his tap, you need to stop his topical steroids. You start them on oral ganciclovir. The dosing we normally start is twice a day, 900 milligrams. We do have ointment Vergan as well available. That's made by Thea. It's not as effective as taking oral. There is a topical preparation, but that has to be compounded by your in-house pharmacy. But you must stop the topical steroids. If you keep them on steroids, the cornea will basically decompensate. So we treated him, the edema resolved, the visual acuity picked up to basically 612. I reduced the dose of his valganciclovir. Normally we keep them on a 3-month dosing. I re-tap them to make sure the CMV has cleared. Remember, PCR is only 70% sensitive when you're doing it in this situation. But typically what happens is because the virus is cytopathic, it'll basically kill the endothelium, so his cell count dropped to 793. Okay, so then he suddenly appeared with a sudden drop of his vision down to basically 6120. He had an epithelial defect, and he had this lesion over here on the anterior surface on the cornea. So what would you do? Start him on empirical antibiotics, scrape and antibiotics, and antifungal. Okay, yeah, so basically everybody agreed, scrape antibiotics and antifungals, so that's exactly basically what we did. And basically what we found was he has an Achromobacter infection, which is a gram-negative species. So he started an intensive antibiotic, we increased him to, we have availability of levofloxacin 1.5%. He's on amikacin because it's often they're quite sensitive to amikacin, but recently we've had an Achromobacter infection which is not sensitive to amikacin and needs ceftazidime, and he's also started basically on natamycin. So we cleared the infection, and then he had a scar, but then his cornea decompensated because of all the inflammation you can see around the back over here. So we continued him on his oral valganciclovir tablets. We found him to have 30% thinning, and he remained on this treatment with valganciclovir, ganciclovir ointment, Tomatropine Cravit. He was on anti-inflammatory for his ketorolac and a mild dose basically of steroids. So now we have this area of thinning over here with a corneal decompensation. So what would you do next? So the choices are, we could do a PK, but of course this is very high risk in the space of the fact it'll be CMV, and this will be a second endothelial kind of surgery. We could do an EK first and then go back and do a dog. Normally we wait 6 months from a negative AC tap, or we can do a dog first, make the thin cornea better, and then go back and do a DMEG. Okay, so dog and DMEC would have been the first choice, yeah. So that's what basically we thought basically was first choice. Unfortunately, what happened was, while I was waiting for the AC tap to clear, he came on with sudden history of pain, and he'd perforated in this central area, and he'd had a basically reinfection of his Achromobacter infection on top of that previous scar. But also, more importantly, his INR had gone up to 8, and he was in severe shortness of breath with pulmonary edema, and he only came in because his basically eye basically was complaining of painful, so we had to admit him urgently. And when I asked the internal medicine guys what we can do, they said whatever you do, you can't do anything under GA, you have to do under local anesthetic. So the option here is basically either we do an open sky PK with somebody with a cough, or there's a high risk of expulsive. And so I was a bit hesitant to basically do that, so I'll show you basically what we did. So what we did is that I did a dog on top of his previous DSEC, so I'm marking out the border, trying to give him some support with a ring to try to basically clear the infection on the surface. So I was pretty sure, well, I was reasonably confident that this wasn't an infection. So I put some anterior viscoelastic in the anterior chamber. So this is a freehand graft similar to the technique I showed yesterday. But here, of course, all the tissue is quite necrotic. I'm going to try to find the plane above his basically DSEC. And the viscoelastic going inside the anterior chamber allows the AC to be formed. Otherwise, it's very difficult to do this kind of dissection with a very flat AC. So as you basically find your plane, I'm trying to remove the necrotic tissue to find the area of where the graft-host junction is to be above the DSEC, removing all this basically necrotic tissue underneath the surface. So as we remove the necrotic tissue, you'll see there's a plane there. That's basically his previous DSEC graft. So you can see there's a DSEC graft underneath there now. And I'm removing all the necrotic tissue basically from the surface. So this is the correct plane now, because the dissection becomes a lot easier as we do the surgery. This is his DSEC you can see underneath there. You can see the whole way he's got a perforation. So I'm clearing away a little bit of the hypopyon inside the anterior chamber. Then I'll put the dog graft on top. So we suture this in place, and then I give intracameral antibiotics, antifungals, because we weren't sure at this time basically what the infection was. So I'm giving the intracameral medication now. And we had to do this all under local anesthetic as well, because of course he was very short of breath and they wouldn't give him a GA. So this is what he basically looked like. So we did a 6.75 millimeter dog. Specimens were sent for culture. We maintained on the antifungal, antiviral, and antibiotics, and we started steroids a couple of weeks basically later. So this is what he basically looked like. This is his infection on the DSEC graft. So 1 month later, his AC-tap was negative with respect to his CMV. There was no fungus. It was another Achromobacter infection. So I went back basically and did a DSEC for him. So here you can see this is the hole basically where he had his perforation. So the graft through is obviously hazy now because there hasn't been a functional endothelium. So this DSEC is pretty much standard way where we'll remove the tissue from underneath the surface. Yeah, at the time we had an intraoperative OCT to help you with the guidance. So I'm just simply pulling out basically the DSEC graft. You can see as we basically take it out, you'll see that actually his perforation had an operculum shape, so it was a triangular shape, so it was bigger basically on the anterior surface and smaller basically on the inferior surface. So because of the adhesions, we're removing the adhesions. This is graft basically coming out. There you go, so put it on the surface, so this you can see is hole, basically where this perforation was. You can see the shape of the hole. You see it's a triangular shape, so it's bigger on one side, smaller on the side in the anterior chamber, and then we just basically do a standard basically DSEC graft. So this is what he's like. He had a 125 micron graft. His ECC is about 2,900. His dog was 6.75. His DSEC basically was 8 millimeters. 16 months post-op, he's had no recurrence of his CMV or Achromobacter, and he's basically just down steroids once a day. I recently did a tap from him, and he's basically AC tap negative. This is basically what he looks like. He's basically gone from this one to basically 2040. I removed some of his stitches basically from the surface. So allowing us to deconstruct the anterior and posterior lamella, reduce the risk of expulsive hemorrhage under a local anesthetic. And for him, it's a much safer long-term management of his CMV because now he's just down to steroids basically once a day. And obviously, more importantly, we managed to clear him of his medical condition. Thank you very much.
Thank you, Dr. Mehta. Very challenging case. We discussed at the end.